Welcome to the tutorial video for mitral valve repair. I'm Pier Giorgio Tozzi, and on behalf of the Swiss Academy for Training Cardiac Surgery, I will be your guide along the key steps for mitral valve repair. We will go through 4 steps. The first one is the surgical exposure of the mitral valve. The second one is a review of the anatomy of the valve. The third one is an analysis of the mechanisms that create mitral regurgitation. And the fourth step concerns the surgical technique to repair a leaking mitral valve. And we are going to use a simulator. We call it humanoid, that has been developed by Lausanne University in cooperation with the Swiss Society of Cardiac Surgery. And this is a dedicated model for mitral valve repair. You will see it's an extraordinary tool to learn how to repair the mitral valve. So step 1 is the surgical exposure. It's fundamental to put cannulas in both vena cava, superior vena cava and inferior vena cava, in order to, just in case, have the possibility of doing a transseptal approach if the mitral valve is not well exposed using the classical transatrial approach. Well, now let's zoom in to see the groove between the right atrium and the left atrium, where I suggest you to make the incision in order to expose the valve. This is the superior right pulmonary vein. This is the inferior right pulmonary vein. Here you have the superior vena cava, and just below the superior vena cava you have the roof of the left atrium. Now, we should look at this groove here between the right atrium and the left atrium. In a real setting, this would have some fat pad here, and the fat pad will guide you in order to carefully prepare this groove. The idea is to pull a little bit, as much as we can, the right atrium towards the upper part of the heart, and you will see this during the preparation. Here is the way you should prepare the interatrial groove, with a smooth dissection in the fat pad. And the idea is to gain some space to better expose the mitral valve. In order to do this, you prepare this area gently, and you should go 1 centimeter far from the edge there. And then with a knife, you should be perpendicular to the wall of the left atrium, and you make an incision. First incision, and then using scissors, you should go towards the roof of the left atrium, just below the inferior vena cava. Your assistant should expose you very well this area, and then you go down almost perpendicularly, close to the inferior pulmonary vein, right pulmonary vein. You should stay 5 millimeters away from the ostium of the inferior right pulmonary vein. So it's important going down towards the inferior pulmonary vein and not going horizontally, otherwise you will open the right atrium, which is not a big deal. You have to close it, but it's a mistake, so you should avoid to do that. Now, for an excellent exposure of the left atrium, you should place the retractor in such a way to lift the left atrium towards the sternum and push it towards the left side of the patient. Now, let's go to the second step, which is a quick review of the anatomy of the mitral valve. You can easily recognize the anterior leaflet of the valve and the posterior leaflet. I'm standing on the posterior leaflet. On P2, you can easily recognize the indentation between P2 and P1. and on top you see A1, A2, and A3. The two commissures, this is the posterior commissure, and this is the anterior commissure, and then the trigons. The trigon is here, is easily identified with a spot here, and the anterior trigon you have somewhere here. Now, I'm going to show also the position of the aortic valve. You can see in red the aortic valve, the position of the coronary circumflex artery, and the coronary sinus here. So step 3 is the valve analysis. We should understand the mechanism of mitral regurgitation. And basically, the regurgitation is due to a lack of coaptation between the anterior and the posterior leaflet. And the cause of the lack of coaptation are basically or prolapse of leaflet, anterior or posterior leaflets, or both, or we can have a problem at the level of the commissures, or it could be done by a dilatation of the annulus, which causes an increase of the distance between the anterior and the posterior, what we call the septolateral distance of the mitral valve. So the most common cause of mitral regurg is prolapse of P2. I'm just standing on P2 here. And you can correct it with a triangular section or quadrangular. We will see this in a while. If you have a prolapse of the anterior leaflet, it's even easier to correct because you just have to add a chorda, neochorda, and we will see how to do it. If you have a regurgitation caused by lack of coaptation at the level of the commissure, posterior or anterior commissures, you just put few stitches to close the commissure, like an Pierre stitch, for example, but focused on the commissure. And if you have a dilatation of the annulus in case of functional mitral regurg, then you have to undersize the annulus. And at the end of the repair, no matter the technique you use, you should use a ring, full ring or semi ring, rigid, soft, whatever, but you always have to use a ring in order to stabilize the annulus and to reduce the risk of recurrency. Now, we will go to step 4 to see in detail all the technique I described. So let's describe the triangular section of P2, which is the most common technique we use to treat prolapse of P2. First of all, you have to identify the area that is prolapsing. In this case, is exactly in the middle of P2. And because the area is limited, we are going to use a triangular section. In case of extensive prolapse of P2, you should use the quadrangular section. Now, I suggest as first step to put a stitch in order to recognize where you're going to cut, the prolapsing area, where you're going to cut the posterior leaflet. And you use a 5/0 proline to expose the edge of P2. And with the second stitch, you can easily identify the area that has to be removed. With a knife, you resect a triangle down to the annulus. So you resect the triangle here, and you also resect the chordae that probably is elongated or ruptured. And then you have to restore the continuity of the posterior leaflet. I suggest to put the first stitch at the edge of the leaflet that we have used to expose the valve. The stitch comes from the atrial side to the ventricular in such a way that when we tie the suture, the knot will be on the ventricular side and not on the edge of the posterior leaflet, which could impinge the coaptation of the two leaflets during systole. I will not tie this one at the beginning. That will be the last stitch to tie, in such a way to see where you're going to place the different stitches to close the gap between the two parts of the posterior leaflet. You can either use a running suture or interrupted suture. It's up to you. The drawback with the running suture is that you could have a post-string effect on the posterior leaflet. So if you want to use a running suture, please lock the suture at each step. Otherwise, you can use the interrupted suture, like we are doing in this case. It's a little bit time consuming, but the final result is much better. Yes, this is the final result. Now I'm tying the first stitch I put with the knot on the ventricular side. And this is the final result of the valvuloplasty. So in order to put the Gore-Tex stitch, you have to identify the papillary muscle. In this case is the posterior medial papillary muscle. And you put the stitch in a figure of 8 using pledget or knot, depends on your technique. Pledget is probably safer than a single knot in order to avoid some tension at the level of the papillary muscle. And the figure of 8 is better than suturing the stitch at the level of the papillary muscle, because the figure of 8 allows you to slide the suture and to adjust better the length, the final length of the neocord. Now, when you're passing your needle, pay attention to avoid to impinge on the chordae that are fundamental for the perfect functioning of the anterior leaflet of the mitral valve. So just avoid to put the stitch through the chordae there. The suture has to go through the free edge of the part of the anterior leaflet that is prolapsing. And then you pass the suture on the free edge of the anterior leaflet at the level where you have the prolapse. The first stitch is from the ventricle towards the atrium, and then from the atrium towards the ventricle with one needle. And you do the same procedure with the other needle in such a way to have a figure of 8. In this case, I put just one Gore-Tex suture, but usually 2 is better than 1, even if the prolapse is limited to a small segment. Now, the key point is to adjust the length of the neocordae. And in order to adjust the length, you should first put the ring. If the leakage is at the level of the posterior commissure, like in this case, it's very easy to correct. You just put a stitch, like an Alfieri stitch, using a 5/0 or a 6/0, depends on the thickness of the leaflet there. And this will easily correct the regurgitation. Theoretically, you could close up to 20% of the coaptation length without having a significant increase in the transmitral gradient after the repair. So now let's put the sutures for placing the ring. The first is at the level of the commissure, the anterior commissure. The needle has to be directed towards the left ventricle, and then you turn the needle holder in order to exit at the level of the annulus. See, towards the ventricle, then it turns and exits at the level of the annulus, or 1 millimeter far from the annulus towards the left atrium. You can put a full ring. We are going to put a full ring, rigid one. As you can see here, we go through the repair of the P2 resection in order to stabilize the P2 resection. And if you don't know where the leaflet ends, you can use the needle, the hook, nerve hook, in order to see where the leaflet starts and where is the wall of the left ventricle. This gives you a perfect idea where the annulus of the mitral valve is. So this is at the level of posterior commissure. This is not a very particular dangerous area. The most dangerous area is the first two stitches we put. They are very close to the circumflex artery, so you have to be very careful in placing the stitches exactly at the level of the annulus, otherwise you risk to impinge the circumflex artery. And here, now we start putting the sutures at the level of the anterior part of the mitral annulus. This area is dangerous because you have the leaflets of the aortic valve, the non-coronary leaflet, and the left coronary leaflet of the aortic valve. So here also the suture has to be placed very careful at the level of the annulus or 1 millimeter above the annulus, no more than that. You can pull on the anterior leaflet in order to expose and to clearly see where the annulus is, and put the stitches forward or backward. It depends on the technique you will use, the one you are more familiar with. And then we put the last stitch at the level of A3, and the suture placement is completed. So the ring sits on the mitral annulus perfectly. And then the last step is to define the length of the neocorda. Now you use as a reference point A1. You can put a hook at the level of A1 or a stitch, and you will ask your assistant to pull the hook or the stitch as much as you can and above the mitral ring. And then you tie the Gore-Tex suture, keeping the height of the hook. And it's better to tie a little bit higher with respect to the plane where the ring sits than to be low. So try to be a little bit higher than the ring. Have to do several knots because that's a Gore-Tex, so it can slide very easily. And you cut it. And that's it. So you remove the hook or the suture, and the procedure is completed. So the take-home message is, if you have a prolapse of the posterior leaflet, you do a triangular or quadrangular resection. If you have a prolapse of the anterior leaflet, you put a neocorda. If you have a commissure that is leaking, just close the commissure. And at the end of the procedure, you put a ring, full ring or partial ring, whatever, but put always a ring, same size as the annulus if it's a degenerative MR, or downsize the ring in case of functional MR. I hope you enjoyed this video, and I think there are no more secrets for mitral valve repair, and I will wish you a successful surgery.